you for giving this opportunity to me, to all the co-authors. And I must say, I was just one of the authors, and you all on the panel have been the guiding force and have been the people who have been contributing to this registry in a big way. So what I'm going to talk about is the paper that we published. It's a 2-year safety efficacy of indigenous abluminally sirolimus eluting stent, which is abluminous. We looked at whether it differs, the outcomes are different in diabetic versus non-diabetic. And this is the link for that article, which is now published in an international journal. So before I go and present the data, let me just take you back through the abluminous DES platform, which is basically a cobalt chromium stent system designed for diabetic and CE approved now for the diabetic and acute MI indication. It's designed to treat diabetic patient with the enVisolution technology, as it is called by the company. We understand that the current limitation of the DES include delayed vessel healing due to slow endothelization and high inflammatory response, which in turn can lead not only to in-stent restenosis but also stent thrombosis. And these all, of course, are reflected into the major adverse cardiac events, which include cardiovascular death, the myocardial infarction of the target vessel, or a re-PCI, as we call as TLR for the same. So the current DES, the way currently the abluminous DES platform comes with certain DES technical specifications, and also we'll compare it with the currently available specifications as compared to abluminous DES. You can see that the crimping is done after coating in the other DES that are available. So it may get affected as crimping is done under the process after getting the coating, while the abluminous DES gets coated after it is crimped. So this allows the drug to be uniformly coating the abluminal surface area prior to the mounting on the balloon. The other important aspect is the dual side coating that goes into the pre-crimped other drug-eluting stents. And this can actually deter the re-endothelization on the luminal aspect, because the drug inhibits the same to the proliferation of the normal endothelial cells inside the lumen, while the abluminous has abluminal coating, which actually causes faster re-endothelization in the adluminal aspect, while the abluminal aspect is the one which is inhibited by the drug, and hence the ISR is prevented. Focal re-stenosis is caused by almost 14 to 16% metal to artery ratio because of inappropriate drug exposure, which is again addressed by this technology, because both the stent as well as the exposed part of the balloon are coated with the increase in the surface area, and hence decreases the drug delivery, which can actually prevent these kind of re-stenosis. Edge re-stenosis, again, which is very often found with the other DES, is because the balloon is not coated in here, because the balloon overhang of the stent is also coated with the drug, and hence the edge re-stenosis, because of the 0.5 millimeter overhang from the stent, is coated, and hence it's also is claimed to be prevented by the theoretical aspects and the advantages that the stents carry over. So the technical specification for the drug, as we all know, it's a sirolimus drug with 0.7 microgram per millimeter square, which is customized with a biodegradable polymer matrix, cobalt chromium alloy L605 with strut thickness of 73 microns, with 80 micron strut width at the hinge and 120 at the strut, with the average recoil being less than 5% and average foreshortening less than 1%, though it's claimed to have zero foreshortening design, but no metal, I would believe, if it's undersized or underexpanded, would end up with 0% of foreshortening. A drug delivery system is the RX delivery system with nominal pressure of 8 bar, RBP of 14 bars, compatible to O14, guiding catheter 5 French, diameter ranging from 2.25 to 4, and stent length ranging from 8 to 40 millimeter, with a crossing profile of 038 with an entry profile 016. So this is like matching the class, all the strategies, all the other competitors that exist, and a lot of the other parameters are much better than that. Especially the strut thickness and the abluminal technology that I just touched upon. Now, coming to the data that was collected for the enAbl registry, this paper was published in the Journal of Cardiovascular and Thoracic Research, which is basically an Iranian journal from Tabriz University. It's a PubMed Index High Impact Factor journal, which is peer-reviewed, open access, and this was published recently in the current edition. It's now available. The other authors were the respected chairpersons of the session, Dr. Dani, Dr. Prathap Kumar, Dr. Devang Desai, Dr. Neerav Bhalani, Dr. Apurva Savda, and Dr. Rutvik Trivedi, and of course all the centers, which were more than 31, that contributed to the registry data, as Dr. Jay himself was part of the same. The objective was to evaluate safety, efficacy of luminous DES in all comer population with minimal exclusion criteria. And as I mentioned, 31 centers with ongoing open registry for all comers in a prospective multicentric fashion was done. This included ambulatory visits or telephonic contact, which is at 1 month, 9 month, 1 year, 2 year, and this has been followed up up to the 5 years now. The primary endpoint was defined as MACE, which was a composite of cardiac death, target vessel revascularization, or target lesion or target vessel revasc at 1 year follow-up, and then it was followed up at 2 years. The secondary endpoint included stent thrombosis as per the ARC definition at all point of times, and MACE was hence assessed at 2 year and then up to 3 years, and then it was continued up to 5 years. So we have published the 2-year data, and enAbl registry is still ongoing, and this actually included all the aspects, not just the diabetic and non-diabetic, but we have just presented one aspect of this, which is diabetic and non-diabetic. And I take the permission from the Concept Medical that we are actually in the process of drafting short versus long and acute coronary versus non-acute coronary data as well. So these were the baseline characteristics we have looked into here, primarily diabetic versus non-diabetic. These were 2,500 patients in all. 2 patients were lost to follow-up who could not be contacted either even telephonically, also to even their relatives. They were excluded from the follow-up. You can see that 859 patients were diabetic and non-diabetic were 1641. The baseline characteristics were pretty much matching. The male predominance was found again in the non-diabetic subset. Hypertensives again were more in diabetic subgroup. Tobacco chewer were matched. Dyslipidemia, again because of diabetic status, these patients were more likely to have it. Renal disorders, again because of diabetes, as I said, these were not cohort matched. This is just the analysis how the patients were looked at into diabetic versus non-diabetic subset. These were also the patients who had higher prior CABGs or prior PCI, almost twice as compared to non-diabetic subgroup, and they also had a higher LV dysfunction with a baseline EF of 39.12 plus minus 12.22% as compared to 47 plus 5.2 plus minus 8.86%. Now, why I'm mentioning these differences, because this also translated into the outcomes. When you had a sicker subgroup of patients being enrolled in the diabetic subset as compared to non-diabetic subset, this was also reflected in the cardiovascular into the CV mortality as compared to those who were non-diabetics. You can see that the prior MI was higher actually in non-diabetics. ACS was again higher in non-diabetics. STMIs were also higher in non-diabetics. The rest of the parameters were pretty much matched, and stable angina was more likely in patients with diabetes. You can see the number of vessels treated. You can see the most of the diabetics required more vessels to be treated, which is again expected. Even the stent length, there was a tendency, but you can see the mean difference was not very different. Neither was the difference between the mean diameter late loss. Mean diameter stenosis is as per the lesion as defined by QCA or reported by the cardiologist putting the stent. Pre-dilatation, 1 balloon, 2 balloon, 3 balloon. Again, there was no difference between the two groups. Neither was the stent length or the lesion diameter or the number of implants as were higher in diabetics as was anticipated in these patients. Stent diameter, you can see this was statistically significant. Diabetic patients had a smaller mean diameter for the stent deployed, and the small vessel disease again was more preponderant in diabetic subgroup, or amounting to 62%, defined as less than or equal to 2.5 millimeters. Patients with long lesion, defined by more than 20 millimeter length in lesion, was not equally matched. As I said, because of the length of the stent, this might have been different, but number of stents deployed were more. Long lesions again was matched. Vein graft interventions were higher in diabetics, and main lesion length in the vein graft was also higher in diabetics as compared to non-diabetics. These are the cumulative results at 1 year. When we look at the loss to follow-up at 1 year, there were 7. When you look at 3-point MACE, again, there was a statistically significant difference between diabetic versus non-diabetic. And these were primarily reflected by cardiac death. As you can see, the cumulative MACE of 3-point is higher in diabetics, but amongst the three individual endpoints, target vessel revasc or target vessel MIs were almost the same in diabetic versus non-diabetic. However, CV deaths cardiac deaths were higher in diabetics, and this was driving the 3-point MACE to be higher in diabetics. When you compare stent thrombosis, there were 14 events equally matched in the two groups, and there was no statistical difference between the diabetic and non-diabetic arm. Now, this goes on to show that cardiac death primarily being higher in diabetics, which is expected even otherwise, was driving the 3-point MACE. And as I showed in the baseline characteristic slides, the patients with diabetes were actually having all the characteristics that were worse, like baseline LV dysfunction, baseline prior revasc or baseline multivessel disease, and these were responsible primarily for a worse outcome, as was noted later on, which we can ascribe to. Again, the 2-year follow-up data, when you can see there were 7 lost to follow-up, and again this was higher in diabetic subgroup, and this also could have contributed to some amount of biasness that we may have with the interpretation of the data. But the cardiovascular death continued to be higher in diabetics. TVMI or TLR were not statistically different. Stent thrombosis again was not very different between diabetics and non-diabetics. So this is one of the kind of first ever study with this kind of technology which has been published in an international PubMed index, reputed peer-reviewed open access journal with an high impact factor, which shows that the luminous has been a safe and effective DES with good outcomes both in diabetics and non-diabetics, with a very low 3-point MACE in the cohort. 3-point MACE again in diabetics was higher and primarily was driven by the CV events in terms of CV mortality, though the target vessel revasc or target lesion revasc or target vessel MIs were similar between both the arms. So this is how the article is doing. Actually, this is almost a week back, and you can see that almost 69 times this article has been downloaded, and a lot of that has come from US beyond India, that their people are showing this in this article from the Tumors Press in the journal, and the abstract has been viewed by almost 300 times now, and then you can see that it is e-published only in 19th May in 2021, and it required 4 months of correspondence before the article could get through. So thank you very much. Thank you for patient hearing, and I hand over the session to the chair.